Hi, David Rosenberg here for the Psychopharmacology Institute. In this CAP, or Child and Adolescent Psychiatry Smart Take, we'll look at the potential role for ketamine, an NMDA receptor antagonist, in adolescent depression. Ketamine therapy has garnered a lot of attention recently as a new, innovative, exciting intervention for treatment resistant adults with depression and suicidality. Fueling the attraction of ketamine's use in suicidal depression is its reported rapid antidepressant and anti-suicidality effects, which compares favorably to antidepressants with their often delayed antidepressant effect. Given that as many as 40% of adolescents with major depressive disorder are considered treatment resistant, there's clearly an urgent need to examine and evaluate new treatment options. In the United States, ketamine is available in IV, intramuscular, oral, sublingual, and intranasal preparations. Ketamine is not FDA approved as a treatment for depression, but intranasal esketamine was FDA approved in 2019 for treatment resistant depression with suicidality in adults 18 years and older. Its use requires both providers and patients to be registered in a risk evaluation and mitigation strategy database to ensure a favorable risk benefit ratio for its use. That being said, ketamine is being prescribed and offered off label to treat depression and various psychiatric symptoms with reported effectiveness. One issue to keep in mind for adults and adolescents is that ketamine clinics are sprouting up everywhere, as this can be a major moneymaker, and not all clinics administering ketamine are the same. It's important to inform patients and families of this and that they do the appropriate due diligence, as some providers take considerable liberty in its use. I'm obviously biased, but I do think at present, academic centers are probably the safest and best option when ketamine intervention is considered. Also, remember, while most antidepressants are safe when used with ketamine, benzodiazepines and opiate antagonists, such as naltrexone, decrease the antidepressant effect of ketamine. There is very limited investigation for the use of ketamine in treatment resistant adolescents with depression. There are a couple of case reports of adolescents with treatment resistant depression and suicidality, with one report demonstrating rapid and sustained improvement, and another report showing more gradual improvement over a 3-week period. In both cases, nausea and dissociation were present during infusion, and in one self-resolved, while in another chlorpromazine was needed. Remember also that dissociation is not considered a side effect of ketamine, but is postulated to be part of its therapeutic effect. There was also an open label study of 13 treatment resistant adolescents with depression who received 6 ketamine infusions over 2 weeks, dosed at zero point 0.5 milligrams per kilogram. And that particular study found that 5 patients, or 38%, responded to ketamine. 3 maintained remission at 6 weeks, and 2 relapsed within 2 weeks. Side effects here included transient dissociative symptoms, infusion related nausea that was treated with ondansetron, and dysphoria. And in the one randomized double blind trial of 17 adolescents with severe major depression, but without active suicidal ideation or comorbid substance use disorders, the patients were randomized to receive a single IV infusion of ketamine or midazolam. Ketamine was dosed to zero point 0.5 milligrams per kilogram over 40 minutes, and midazolam, which served as a placebo control, was dosed at 0.045 milligrams per kilogram over 40 minutes. A single infusion of ketamine significantly reduced depressive symptoms at 24 hours after infusion compared with midazolam, with a very strong effect size. Over 75% of adolescents with severe major depression responded to ketamine versus 35% of those treated with midazolam. So, what's the bottom line? This is an incredibly promising area to pursue, but ketamine right now is definitely not ready for routine primetime use in adolescents with treatment resistant depression. Interestingly, the aforementioned published studies of ketamine used IV preparations. However, in adults, the FDA has approved an intranasal preparation for ketamine, intranasal esketamine. When asked, many parents, not surprisingly, prefer the intranasal option. The studies to date are clearly preliminary with very small sample sizes, and more placebo controlled studies are needed in adolescents with treatment resistant depression, with and without severe suicidality, examination of optimal dosing and titration, way of delivery, etc. Of note, this report was written by two child psychiatry fellows at Stanford. They are to be commended for an outstanding and thoughtful review and roadmap for further study. Exciting times ahead.